Got it. Okay. So, Congressman Jackson, that you kick off. I'm not expecting you to give us the solve all the problems, but we know that you have an opinion and are strongly committed to this. I'd love to hear that you tell people a few words.
I should put this speech down.
No, go ahead, read it. We're gonna get some. I'm gonna get some coffee, and then you can get
Mr. Speaker, I rise today. Hey, Jonathan Jackson, pleasure to be a part. It's an issue I care deeply about. Thank you very much for getting us together, Brother Keevan.
Thank you. Okay, all right, good. Delegate Tran.
I'm Kathy Tran. I represent the 42nd District in the Virginia House of Delegates, and it's an honor to be with you all today and look forward to sharing our work in Virginia.
Pleasure to be with you.
Next is Endura Galvan. Endura is a longtime expert in healthcare. She's Color of Health is her organization, and she's been all over the country working on this, and she's got personal caregiving history and a lot of policy experience. So, Endura.
Hi, Endura Govan, Color of Healthcare, based in Washington, D.C., but we serve nationally. Thank you, Keevan, for the invitation to be here today.
Awesome. Thank you. Thank you. Now, unfortunately, Dr. Dunn, we lost her. She wasn't able to be here. She has some comments, which I'll read later. But we got Wesley Hodges. Wesley, is he on? Yeah, there's the Hodges Foundation, which is also the group down in Alabama. They're working on health equity. We have a lot of focus on rural, and I see Frank with the Black Mayors from Arkansas is on as well. But Wesley, say a few words, and then we'll move over to Frank, and then I've got Q&A. So go ahead. Wesley? Okay.
Yes, we can hear me.
Oh, there we go. Now we can hear. Yep, go ahead.
Hi, how's everyone doing this evening? This is Wesley Hodges of the Hodges Foundation, Rural Economic Development Foundation out of Alabama. I met Mr. Kimball. I haven't met Ms. Tran or Ms. Endura, but Congressman Jackson and I have crossed paths in Selma. His father and I have been in Selma at the bridge crossing Jubilee. My first time meeting Mr. Congressman Jackson was last year. So it's a pleasure to see you again. And I'm trying to get my video on here for some reason.
There you go.
Okay, there we go. Yes, sir. But I've seen Congressman Jackson in Selma, my first time meeting him last year, and his father and I have been friends for many years due to the bridge crossing Jubilee. So it's a pleasure to see everyone here. Look forward to hearing perspectives from everyone today.
Thank you, Wesley. Frank, I don't know, are you on, Frank?
Yeah, I'm here. I'm here.
Okay, so Frank is the executive director of the Arkansas Black Mayors Foundation, and I know that healthcare is a big issue. We've talked many years about their lack of funding and need. So, Frank, please say a few words.
Yeah, Frank Bateman, I'm the executive director of Arkansas Black Mayors Association. We have a health component, and in our health component, health equity really kind of came to light here in Arkansas a lot more when when COVID set in and hit, and it really kind of blew up the disparities that we have here in Arkansas, around the state. The mayors, I think that they managed it and did a lot of stuff real well. We were able to hit the ground, get the word out, get the shots out, and all the things that went along with COVID. But even since COVID, we still have issues here in Arkansas. Syphilis, gonorrhea, HIV is real high and prevalent. So those are some of the equities that we constantly fight, and lose a lot of our people around those issues. So I'm looking forward to hearing what y'all have to say, and maybe we can use some of that information here in Arkansas.
Awesome. Thanks, Frank. Thanks a lot. So I'm gonna jump off into the start off with a Q&A, and just I think the good way to frame this conversation would be with Delegate Tran to kind of talk about what she did legislatively and what her thoughts were, and what she thought the history and the future going forward might look like.
Great. Thanks so much, Kevin. I really appreciate it. So as I said, I'm Kathy Tran, and I represent parts of Fairfax County, which is in Northern Virginia, in the Virginia House of Delegates. And tomorrow on the 27th, I believe, will be to the day where the article from the New York Times, I just re-pulled it up, really brought this issue to my attention, which focused on a hospital in the East End of the Richmond community, and how that hospital system over years has really taken their 340B savings out of a predominantly Black community and have been reinvesting those savings into wider, wealthier parts of the city and the surrounding areas. And when I read that expose, I mean, I was furious, and started just kind of texting all the folks I knew who would care about this issue, both on the legislative side as well as in the community. At the same time, community members were also organizing themselves. And so we all kind of came together, a couple of us, it was my office, it was the Richmond Coalition for Healthcare Equity, the Virginia Interfaith Public Policy Center as well, and some other stakeholders. And we really looked at ways at the state level that we could really mobilize and push on more transparency in the 340B program. And I want to preface by saying that clearly, right, what 340B shows us is the extreme high costs of prescription medication. And so this is not an effort to undermine the program. And I know there are kind of those outside forces as well, and we want to be cognizant of that. What it shows us is that prescription medication is, outrageously expensive, and we do need programs like 340B and other efforts to rein them in order to make medicines cost more affordable, these prescription medicines, so that they're much more affordable for people who are particularly vulnerable. And so our bill, I felt, was extremely simple. It was taking the American Hospital Association's good stewardship principles that are voluntary, that many participating hospitals in Virginia already sign on to, and just requiring all hospitals that are participating, except for the certain types of clinics, to make sure that they're reporting on those factors, and they are really to disclose what the estimated savings are through this program that they're receiving, to commit to conducting internal reviews to ensure the integrity of their program, and to communicate the overall value of that program. And unfortunately, we were not able to pass this bill. And I think that there are still lots of educational efforts that we need to take. And I think helping to reframe the situation, and we tried to, right? It came from an article that exposed, I think, a lot of serious concerns about the current status of how one hospital in Virginia was using the program. And so this is not from we don't want to necessarily be punitive, but it's a chance. If you're a hospital and you're doing good work already, that you should have the chance to tell your story. And if you're doing good work, then you shouldn't be afraid to tell the story to the community. And it might also gather additional community input and discussions with affected community members about the best way to reinvest. So I think that there's an opportunity for dialogue and conversation and true partnership that can happen from this type of transparency. And so we're talking to partners and thinking about what are the best steps in Virginia this coming year. I am particularly heartened to see states like Maine and Minnesota consider and pass their own versions of transparency bills for the 340B program. But I think kind of that push from Congress is also going to be very important, because I also understand you want to understand, I think, from a policy level, how having some consistent data about the program across hospitals across the country. But for us here, we think that there is, for hospitals that are doing it right, a real good story to tell and an opportunity to strengthen that conversation locally.
No, thank you. That's you did a better background than I ever could. That was awesome. So thank you for saying that. And I will point out one data point that the drugs purchased under the 340B program have gone from 5.3 billion in 2010 to 38 billion in 2020. So it's multiplied by almost 8 times in that time, the amount of money spent, and the average discount is 59% off the drug price. So hospitals stand to make, what, half 40% or 60% of $40 billion, almost $24 billion in savings just with that process. So it's very important that we make sure that underserved communities, because all of the health equity numbers show, the health disparity numbers show that we're losing ground in this space, but there's a lot of money being spent. So that's the conversation we're trying to have. And I would ask Congressman Jackson, or ask everyone on the panel, or Endure. Let me start with Endure. Where do you think, you're on the ground, you're working, do you ever see evidence that 340B money is making its way to the patients that you're serving?
So yes and no. Those who know about it, but using myself as an example, who was a caretaker for my oldest brother who had dementia, I'd never heard of 340B. I was okay with my own insurance. But when you're a caretaker for someone who the National Disability Institute describes as Black and brown, sick and poor, living under the bottom rung, and the way that they are treated, you have to search for ways to patch up the money gap. My brother had certain things. He was diabetic. So for instance, his test strips weren't included for some reason in his insurance. So that made me dig for resources. And that's actually how I discovered the program to supplement with his own income, which is what I was trying to do, help him live so that if I'm no longer able to be his caretaker, that his life can support his illnesses. And that just didn't happen. I know of seniors who are paying in co-payments what they're paying in mortgage payments, and they are drowning. I talked to a lot of seniors who are saying, I did the right thing. Why am I in this situation? I went to school, I got several degrees, I took decades to pay off my student loans. 209 happened, I lost most of my retirement. And just as I was building again, COVID happened. So I'm back at zero. And these are people with 3+ chronic illnesses. With my brother, I was actually managing 8 chronic diseases. So that's a lot of money spent on prescriptions. When I look at some things that can be a solution, it's informing where the people are, where the eagles gather. I actually had a pharmacist from a national brand when I complained maybe 5 to 6 visits. Why isn't this covered by insurance? He was the only one on staff that pulled me over to the side, whispered in my ear, you're actually in the wrong type of pharmacy for your brother. There are other types of pharmacies. But had he not been one of those angels that I found along the way, I would have continued to pay out of my pocket. And I look at the millions of people around the country who don't have informed people telling them where to go and what's out here. If we look at the $178 million that was dispersed to the same clinic under COVID, on top of what we're already receiving. A lot of us on this call are entrepreneurs. So imagine if you got a contract to serve underserved people, but you didn't serve them, and you continue to get bonuses for that same group. but you don't serve the group. It's almost notices need to be similar to a restaurant where it says, and I say this jokingly, but I am serious, where it says employees must wash hands, because we see that everywhere we go. But yet, with a subsidy like this, that makes the difference between a person being in a black with their money and being in a red every single month, it should be where the Eagles are gathered. That could be church. It could be um, the locals farmers market during that season. We have Representative Jackson who sits on the ag committee. So just imagine as you're picking up your subsidy from the farmers market, you get information about your subsidy for your prescription. I think my brother may have had 12 plus prescriptions that he was taking every month. And it's such a big burden. But yes, going right to where the people gather and maybe making them a voice to Big Pharma and the other people who are getting these entitlements. It could be a community pressure, but there definitely needs to be a pact. And PAC meaning pharmacists and politicians, the advocates and the community all working together to make this program work to the letter of the law of what it is supposed to do.
Thank you. That's good. Your story is always, I love having you on these, Endure, because your story is always so poignant. You've seen it. A lot of people make policy, they've never seen it at the ground level. So you're good at translating that. So Congressman Jackson, I'm going to put you on the spot. You'll say, what's the likelihood, or could we make it so that when people go for their food stamps, they get their 340B or notice, so they know what they're eligible for? I mean, what would you see, or how could we leverage this? I know they're doing the farm bill now, so how could we leverage that kind of operation?
This to me comes back down to equal protection under the law. It's the enforcement of the law. It's on the book. Certain people qualify that don't get access to it. So I think there should probably be a potential government program or notification that these programs have to be aggressively promoted and shared. Kevin, we saw the same thing happen with the mortgage market. People that could have and deserve to have a lower mortgage simply were not offered that mortgage in the mortgage market. Now, this is the same thing with the medical insurance. So I think that's the same template. People aren't being notified what benefits they have, and those that don't qualify, those that were unintended, take full advantage of it, and those that didn't. Well, I can't say didn't need it. I don't agree with that. The prices have been too high, so we get into a real dicey area, saying these people are overpaying because they have more means. No, they were overcharged also. So everything is broken about it, but let's follow up on that.
Okay, no, I appreciate
it. But it's the same discrimination and access to services.
One of the reasons why, I was glad you'd be here. You understand this economically at a whole bunch of different levels, right? So it's like you tie in mortgage things, and then there's at every level there's money out there for people and they don't get it. So you're one of those people who understands that. So I wanted to tie you into this, rope you into this process, this fight with us as we try to make hay. One of the other things we've been thinking about, and I'd love to get your opinion on this, is how we might make it so if we're doing this, the points of light, like Endure said, the civil rights groups or church groups or others can then get access to the money. Someone like the Hodges Foundation in rural Alabama, how they could actually get access to funds to help educate the population through this process. We can talk about it later, but I know that Wesley, that's something you guys have been talking about. What do hearing this? Have you guys heard of 340B? Have you done anything in that space?
Yeah, the directors had heard of the 340B, but myself, I had never heard of it. In healthcare policy, care reformation, anything, it's basically down here, man, you don't really have any access to information. You don't have access to the resources, the information on the resources. It's a lot of stuff that we do not have access to in the areas that we are in down here in Alabama. It's not just my area in West Alabama. This spans across what we call the Black Belt of the United States. It spans across the entire Black Belt. And it's not just the state of Alabama. It also goes all the way up to Virginia, Maryland, Eastern Shore. That there are these areas that do not have the information and access to the information on these resources. It's just kind of hard. And when we do get them, getting someone to getting someone, I'm trying to say this without insulting them. So getting someone in the position to be able to comprehend the information that they're getting is even more difficult. So it's really hard to not only get the resources on the information, but it's also difficult to have the people in the position to be able to facilitate those funds. So our foundation, we did a lot of groundwork, a lot of feet on the ground, and a lot of research and data collection in order to try to be like the go-in between for the entire Black Belt. I know that's some people say that's a hard thing to do, but we spent our time trying to get the credentials and whatnot to be able to bypass the question, could they handle this type of funding, or could they handle these type of resources being dropped on them? So that's what we did in our whole entire process of starting as a foundation. We just made sure we were rigorous on getting framework structure and having the personnel to be able to facilitate these types of things, these types of resources and funding. So yeah, that's where we are now, just trying to make sure people know who we are and what we're seeking to achieve as an organization. And collaborations always work, especially down here in the South. Collaborations, that's really the only way you can work down here because of how the system is. I don't have to go into explanation on that, but it's just, how the system is. Ms. Tran, I know you have a totally different perspective, because I've lived in Fairfax County in Centerville, and the amenities are lovely. Fairfax is one of the most, you guys are one of the most well put together counties in the nation. So I commend you on that as well. But yeah, you guys have a totally different perspective of what it is needs are compared to us, even though all of us have the basic essential needs, as compared to the funding here and the funding here in the areas. It's a little different, but the essentials are always still the same, honestly.
Thank you. So, I mean, Dr. Ifume, you weren't on the panel, but I can't let you get on this call without asking you to kind of weigh in on this. I know you have a great experience, and we'd love to hear what you got, how you take this, and what you're hoping to see happen going forward.
Hi, thanks everybody. Thanks for having me. You almost had my name correct. It's Dr. Ifeoma Udoh. You don't have to say the doctor part unless you want to, though.
I'll do the whole thing. I want to give you earned that, doctor.
I did. That's true. And I'm with the Black Women's Health Imperative. I'm the Executive Vice President for Policy Advocacy and Science. And a huge part of why that makes the most sense for us is that policy must be driven by what we know out of data and science. And so I guess in agreement with most of what I've heard today in terms of the need for the transparency and the reporting with regards to what is actually happening with this very important health policy. This is an incredibly important health policy that is meant to address health equity in this country. So the fact that we even have it and it's been around for 30 years, quite honestly, is to the credit of Congress, who put it in place, who had the wherewithal to put something like this in place, knowing the extreme cost even 30 years ago of pharmaceuticals and how much more expensive they've gotten over time. This is actually one of those good health policies that we should be really proud of in the United States. So let's talk about how we make it work and how we make it work better. And I agree with the issues of transparency. We know that the average discount and using the 340B pharmacy program should give at least a 50 to 60% discount to members, patients, the folks that they are supporting on their very expensive pharmaceuticals for everything from HIV to diabetes meds. It should be that significant of a cost to people who need the support. We know that that's not happening. The reason why that's not happening is the transparency and the lack in the reporting. But I want to argue that also the reason why that's not happening is that we're not seeing enough guidance around where those savings should go. And so directly linked to policy that says, please report, and it should be monitored routinely, and having a monitoring board of advocates, of our legislators, of our policymakers working joint in hand with organizations like BWHI, the Hodges Foundation that we heard recently. To have a monitoring board that's paying attention to where those funds are going should definitely be something that we should consider as one solution. Another solution is that we need to consider having some guidance points on here's how this money should be spent. If you're in rural settings, or this money is coming through hospital systems that are in rural settings, given that there are service deserts in a lot of the rural settings that we know in the South, you must put this money back in support systems that are going to impact people who are trying to get services in rural settings, whether or not that's transportation so they can get to and from their clinic appointments, or whether or not that's different forms of healthcare that are mobile so that they can get to appointments that are closer to where they live, right? So we've got to not only just say, let's create some transparency and reporting. There's lots of recommendations from community-based organizations locally and nationally around how to actually fix some of the health equity issues that we're seeing in this country. So we should put some of those recommendations in those guidance documents and those policies as well.
Well, let me ask you this question, because at CLC, through the Poor People's Campaign, one of our big issues is minority ownership of infrastructure. So whether that be stores or factories, and we've added healthcare facilities to that. What do you think? Is it feasible to make that one of the requirements, that some percentage of the money, 5, 10, 20% of the savings be used to build out minority-owned health operations in different, so whether they be pharmacies or hospitals or clinics, using that money to do that?
I think that could be conceivably one way to approach it. I think it's going to be from place to place, right? I mean, in some, and supporting minority-owned businesses also too requires a lot of infrastructure supports. And so then the question becomes, are these funds meant to support back in that way, or are they meant to support back in expanding access to care for its constituents? And I think there's all kinds of ways that we can think about what expanding access to care means, inclusive of supporting minority-owned pharmacies, for example. There's a Black pharmacy in my neighborhood. I live in Oakland, California. There's a Black pharmacy in my neighborhood that I routinely go to and prefer going to versus CVS, right? And so that could be one way to support that community as well, depending on what is actually happening in the local environments. And so those recommendations should also come from what is going on locally at the state level as well, in terms of supporting health equity.
Awesome. Thank you. Indura?
Yes, I'm here. Something happened with my camera, but I am here.
No worries. No, so what do you think, in terms of recommendations? You mentioned, actually had a lot to say about, where the Eagles stand, but how should the money be used? Like, we're talking about recommendations beyond the knowledge base. How do we use this money to better encourage health equity? Because, it's not, we're all healthcare consumers, but that seems to be just one part of the process. One of the real problems we have is that the people who control the process or the infrastructure don't live in minority underserved communities. They don't live in rural Alabama. They don't live in urban areas. So their desire to serve those areas seem to be lacking. And I'm gonna touch you too.
There are just so many layers to the onion. One Lord giveth, another Lord taketh away. But altogether, there's too much money being deployed for people not to be served. is the bottom line. And then backing in a way geographically, because no area is the same. DC is different from Chicago, which is different from Fairfax. But a solution has to be made. Transparency, just starting there, could go a long way. I should not have to make 20 calls because I am that person. I'll make 100 calls if I have to find a solution. The solution to the problem should be at my face where the problem is happening. I've been in mainstream pharmacies, and I'm sort of that person that's going to butt in when I see someone walking away with their head down because they cannot afford their prescription. Then I'm that person asking them to turn around, go back, and ask for the reduced prescription. But why isn't it posted at the point of use? Starting with your primary care physician. The questions I asked my brother's main doctor, he didn't tell me the solution to the problems for his prescription. When I said, can you write generic prescriptions that may cost less, and then my output for him is less? His primary care physician really should have been the first person telling me what to do. So I don't have that one-shot solution. I am so glad that even on the Supreme Court level, that they bounced it back to Health and Human Services, and they didn't make a decision. Something needs to be done over several layers of serving the community that these monies are deployed to fund. I look at what I could even add up that was being spent on my brother, who made less than $20,000 with his disability amount. And there was almost $700,000 annually being spent on him. So surely at that level of spending, the quality of his life should have changed. Mm-hmm. And then the people who don't have a crazy little sister like me that are pound the payment on their behalf and advocate and call a mayor's office and do whatever it needs to take to make sure his quality of life is better. I can only imagine the hell that they are going through, not having advocates like the people here on this call fighting for them.
Thank you. Delegate Tran? So that same question to you about solutions and are you planning to do more legislation this session or next session, I guess, coming up? And and how might we put more pressure on the system by having more competition, by having more minority-owned health institutions?
A couple of thoughts. I mean, there's, I think at the state level, we can continue to push for transparency. And we've had a couple of groups ask already if we are planning to reintroduce this bill. I definitely want to chat with our local advocates who are in the community, who have been discussing this issue with the hospital, during and post session. And so I think we were able, by virtue of introducing legislation, able to highlight this problem to the General Assembly, and that they're continuing those conversations. So we want to be in concert with their efforts, and we're going to have that conversation. But I think kind of additional solutions, and I think the doctor mentioned some really important aspects that we can't ask for at the state level, but can be within the federal parameters for the program, is this issue around transportation. So what's happening for some of our, as you well know, under-resourced hospitals is like, if you need to be transported to another kind of bigger, more major facility that is close by, but there's no transportation to get you there, the ambulance system is, not up to snuff, and there's too much of a long wait, like that's impacting your healthcare and your ability sometimes to survive, quite frankly, your crisis moment, right? And so how do we invest in that transportation infrastructure? And can you and should you use some of these savings to do that? I think as a federal, federal guidelines would be really helpful there. I think the other piece that's come up, and I don't understand this piece as in depth, and so this is a education on my part that we're undertaking, but perhaps somebody on the call understands, is my understanding is sometimes some of the medications that are prescribed within the hospital cannot be accessed by the hospital pharmacy, but like you have to go to a local pharmacy. And if the 340B savings, does that go confer then to the local pharmacy? And if so, are they also required to reinvest in the community? So I think there's that question that has come up also since we've introduced this bill, and what, if any, leverage there might be there to make sure that all the savings that are realized are being reinvested, right? So I think that's something we're interested in knowing, but I do think that is probably more likely, I would imagine, a fix at the federal level, or something that Congress would have to address, or the Department of Health and Human Services would have to put in guidance. But I think that as we look at opportunities to expand health equity and make sure that everybody is getting the services in a meaningful, timely, affordable, and high quality manner, we should also look at everybody on this call and how do we broaden that conversation, because it's our rural communities, it's our API and Hispanic communities that are also impacted and face significant health disparities. And how do we make sure that we are engaging, that awareness is out there amongst other communities, and that we're able to have that level of engagement as well, because I think it'll take lots of us to help turn this around.
No, that's, I think the fight is a big fight. So I think a lot of soldiers are going to need to be had. Thank you. Yeah. We're about 15 minutes to the end. And so I want to open this up for Q&A. But if any of the other speakers, the panelists, Congress, if you have any other words you want to add before we do Q&A or an endure.
I would like to just comment on something Delegate Tran said. And this is from my perspective, so it, may not be broad, but please don't dip into transportation funds from medical funds. And I'll give you an example. My brother was able, through his insurances, and including Medicare, to access Uber Health, Lyft Health, the local, I live in Washington, D.C., so the free metro access, a $5 taxi cab. He had about 7 modes of transportation. So adding a dilution of medical funds to a whole nother industry could further prohibit the people who need the medical assistance on their prescriptions. And that's just my personal opinion. Transportation is important to what you said, but most states, they have the additional means of transportation that a person can access.
Thank you, Endora. So,
yeah.
Congressman, you want to say anything before we move to Q&A? Okay. So Q&A, guys.
Let's go. I mean, this is I'm engaged, and I'm sorry, I'm just swamped trying to get something else out by 5. But I'm with you, and this is like really, I'm not familiar with 340B, just from what I read and what I was briefed on. So it's an issue that I do care about, and I would like to champion. And I can tell you several other government issues that I've had concerns about being notified of what is available. So please, I'm all ears.
Thank you. I just want to make sure that we're going to open up to the rest of the audience. So thank you. So anyone have any questions, please raise your hand or chip in, and Brady will recognize you. If no one has any questions. Oh, Ophelia has a question. Go ahead.
Yes, I just want to know, is there any way you can forward to us a synopsis of this bill? Or I'm understanding it's been in place for many, many years. And of course, in rural Eastern North Carolina, health disparities is an issue, and our citizens getting the much needed care. And with the income level, I'm thinking this is very helpful some may know about it, some may not. And when I say some, I don't mean the average citizen. I mean healthcare facilities and doctors are aware of this. And is there an income threshold that one has to be aware of to qualify? I know you said someone mentioned about getting the generic prescription written versus that's a lesser cost. I guess I've asked several questions or concerns. One is, can we get a copy of a synopsis of the bill, what it addresses, and how we can address healthcare facilities or clinics in our area that can better serve our citizens here in Eastern North Carolina?
Yes, and yes, and yes. So we'll get you on that, Philly.
Thank you.
You're welcome. Deborah.
Yes, good afternoon. How's everyone?
How are you?
That's beautiful. That's beautiful. That's beautiful.
Great. I got weird feedback. Quick question. Will there be a follow-up
situation?
Okay, that sounds weird. Will there be a follow-up to this continue the process so it doesn't just end here, so that maybe we can track the progress, because there's a lot of moving parts, both from the the government level to the local community level. And I think it would be a good idea to just sort of keep that going, and try to create some sort of a steering committee out of that so that these changes can take effect as recommended.
No, I think the plan is for this to because we're trying to affect change. So the plan is for this to be sort of a working group kind of operation, and letters will be written, op-eds will be written, and there will be more activity surrounding this. So short answer is yes. And we've got everyone's emails here, so we'll start to disseminate information and request feedback and have other meetings as well. So thank you for asking that question. Tracy.
Hi, good afternoon. Great information. I was just wondering, I think you might have answered this about a quick synopsis. And then I was wondering, will any of this be pertaining or speak to small business owners and entrepreneurs who may lack access to healthcare?
That had not come up, but we can do that. One, we're going to work on a synopsis, and secondly, I want to introduce you. So, Delegate Tran, Tracy is with the Leading Ladies of Richmond, so she's actually in Richmond, Virginia. So her and her group are very, very big on economic inclusion and policy inclusion. So I encourage you guys to meet up at some point. And Tracy, yes, I don't know the answer. If anyone on the call knows the answer to the question about the entrepreneurs, let me know. But we can, if not, we can follow up and get you some answers.
Consequently, everyone, I put in the chat a link to the 340B overview, 340B program overview.
And also put a link to the white paper, our health equity white paper from 2 years ago. Any other questions? Nope, I don't see anybody. Oh, Celestial.
Celestial.
Hi, good afternoon, everyone. Not really a question, but just a chime in. Please do not forget about Mississippi. Let us know how we can be involved. Thank you.
We will keep you on. You're on my list, Celestial. Dr. Say one more time, Dr. Ifuma.
Ifoma.
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 Dr. Ifoma.
Yeah.
Go ahead.
I think more, and this might be sort of linked to what Celestial said, quite honestly, I think more than anything, this is a comment, BWHI is really interested in being a part of the ongoing conversations that are supportive to our legislators and our communities about what should happen with the influx of resources that comes through when we clear up the transparency issues with the 340B pharmacy pricing. This is incredibly important in states that do not have Medi-Cal expansions. That there was a note about Mississippi. Let's not forget Mississippi. that's also really important to not forgetting all of the states that do not have expanded access with regards to Medicaid, because again, this is a federal policy. It's a federal policy that is actually a good one if we can get it to work. And it should also really be to the benefit of a lot of those states that did not expand Medicaid. And so I think that's an incredibly sufficient point and an important point. And I think our members of Congress and our legislators here and Representative Tran, I really appreciate the work that you're doing in Virginia. This is low-hanging fruit. This is one of these things that can be fixed, right? Like it's a really great bill, and it's one that like directly ties to health equity, and it's one that actually can be fixed. And so we have to have the motivation of our congresspeople and our representatives to push that. It can be done.
Awesome, thank you. Elroy, you have a question?
Sure. Yeah, I would like to recommend, Keevan, again, thank you for your leadership, and Delegate Tran and the congressman and everyone else that's participating, Dr. Fumi at BWHI. We have a lot of comprehensive healthcare organizations represented on the phone from across the country. So more so to our elected officials on the line, one of the things, Keevan, with your leadership, as we begin to write comments and try to help change policy, is to make sure that as we begin to think about the dollars that flow from the manufacturers to the pharmacies and to the hospitals, and then the end users being the constituents, people in our Black, white, and brown, rural and urban communities, even if we get transparency, even if we get responsible leadership, there's still a gap between that pharmacy and then the people that live in the neighborhoods. So unless we have your BWHIs or your SCLC GPIs in the gap, my fear is that there still will be a lack of communication and a lack of information to let people know in the community know how to access these discounts. So again, my point, I'm more of a statement than a question. It's just make sure that as we go through this and look for policy change, that we don't forget, even when you get the policy change, you still have to have the trusted community leaders from our communities that can partner with the private sector to make sure that that information is freely flowing. So in closing, as we try to change language or executive order or do something on the policy side, I would encourage all the healthcare groups to submit. I know there is a Senate 340B working group in Keaton, maybe with your leadership, we can continue to submit language that says these healthcare organizations, there should be some kind of mechanism where the private sector's contracts and works with the healthcare organizations to do the advocacy, education, and training.
That's a good point, Elroy. Thank you. Thank you. Gustavo.
Thank you, Keevan. It's a very good conversation. I actually, prior to Mr. Sadler's, Dr. Sadler's comments, I really was going to mention in the aspect of navigators or promoters who are even those who are affiliated with other community-based organizations that can partner with the health with the health organizations, because I agree that there is going to sufficient gap, and especially when you get in rural areas or Latino communities, emerging communities, that there's a distance between, say, a community health organization that many people have to travel 10, 30 miles, that there's some effort or perhaps some funding that will go and specifically allocated for navigators and promoters in various areas of the country, so that these individuals through some mechanism can make constituents aware that this program is in effect. And the fund should probably be a combination of the pharmacy and sort of in what's coming out of the bill. And so that's something that I agree, and more specifically about and training and providing and giving them and enfranchise them and empower them to go out in various communities. And also some other aspects that even you get in Indian country, sometimes with Indian health services, that even gets in a little bit about understanding that as part of rare disease or many of these medications, that is also available, that perhaps individuals within the Indian health centers, which are always not the very best, that they're aware that although their medical coverage is covered by Indian Health Services, that they're aware that this medication and these things, life-saving products, are available.
No, that's a good one. I think we're going to figure out a follow-up. We're going to have some more calls on this and keep moving forward, because we do know that one reason I want to get this group together is that you guys are all leaders for doing this in this area. I know you've discovered, you got, not only do you have Latino and Afro Latino, and you also have Native American, because you have a huge network of people, and we've been talking about trying to make sure they all get engaged. So it's a great deal.
Sorry, Kevin, I've got to go, but I want to say thank you.
Oh, thank you, Congressman. No, appreciate you. You'll hear from us. We'll come knocking on your door at some point.
The door is open. You got the key. See you. Bye-bye.
Wesley. Wesley, you had your hand up?
Yeah, two quick comments. Okay, the first comment was regarding transportation. First comment was regarding Ms. Endura. I think that was who it was, the transportation and healthcare comment. There is a way to separate the two and ask for both funds, or if we as a panel decide we should just stick to healthcare transportation under healthcare, we should at least as a panel be able to give a list of transportation models that are available for us to do, because again, Ms. Endura, in your section, in your area of the nation, it may be a little different from Mississippi and Alabama, the rural South, where we don't have access to Uber anything, Lyft anything. Yeah, all that stuff, all those models work well, and they're great models for larger population demographics. But here, it's very hard to get Uber or Lyft to even entertain something, because everyone's so spread out. So just if we do have transportation, don't want to go for both transportation and healthcare, because again, transportation also entails ambulances and fire trucks and all the other things that save lives as well. Just keep that in mind. But that on that point, we'll discuss that next meeting too, hopefully. On the second comment that I want to give you was, I see most everyone's concern here is trying to have a mediator or go in between for getting the healthcare resources and amenities to the rural areas. So for the follow-up, and I'm glad Mr. Kimball is providing us with a follow-up, I have one of my director for the Health and Human Services department in the foundation, Mrs. Polk, and Dr. Hawkins, they will hopefully be able to attend this next meeting, so they can give you all their health care rural healthcare initiative program that they have set for pretty much any rural area. It's a work plan that involves a collaboration of universities, hospitals, university hospitals, and primary care physicians. I heard that was a concern as well. Working all together in a collaborative model that allows one or two organizations to be mediators for facilitating these services and amenities to, including pharmaceuticals, to the rural areas, straight from, I guess, the policy itself. Honestly, yeah, pretty much.
Awesome.
Yeah.
So we'll put that on the agenda for the next one. We will definitely go down it. Delegate Tran, you had your hand up?
Yes, thank you. I wanted to follow up on the doctor's point about this being a low-hanging fruit. And when I opened my comments, I mentioned that Maine and Minnesota, in addition to Virginia, had introduced state-based legislation, but I did a quick look. Indiana has as well, and some other places. And so I think what you're seeing is Indiana and Connecticut are two other states that I just read about. So I think what you're seeing is in both blue, red, and purple places, right? This issue is bubbling up. And so while you are pursuing both the federal changes that are needed, both legislatively and like policy regulations wise to increase the transparency, to have better understanding of how you can use these funds, how they should be redirected into a community, and the investments that are going to really be necessary for systemic change, both healthcare delivery and the relationship that healthcare access has with transportation, like we've been talking about, and on. I think that there's also needs to be a state-based approach too, just because we recognize, right, that how divided Congress is right now. And so I think though, if you're, and so looking at different state models, I think is going to be really helpful so that you're not forgetting the Mississippis and other places, right? If citizens are able to organize and work that way to find a champion in your state legislature. Because if you look at the different legislation that's been introduced in these 4 or 5 states, they range in terms of what is required. I think what we did in Virginia last year was extremely basic, but I've heard some of the other models are a little bit more complex and have more transparency so that when you start getting that data, you can then point out, right, how things are working, how they're not, who's being served and who's not, and really get down into the nitty gritty. Then I just raised that as you're looking at your paths forward is how do you do this both state-based and federally, and then the myriad of ways you can tackle it, because I do think what you're starting to see is really bipartisan support for reform.
Awesome. You've been a great leader on this, so thank you. So we may come knocking at your door again as well. So it is any more questions? We are at time. I don't want to keep people. I know. Thank you all for taking time to get here, be on this Zoom. I know it can be difficult and technology, but Ophia's on vacation and other people doing stuff. So I appreciate you guys taking the time. So unless there's any other, this will be recorded. So if you need we'll have the video available if anyone wants to watch it again or get access to it. And with that, no more questions. We'll end this. Thank you all.
Thank you. Bye-bye.
Thanks, everybody.
Thank you.
Thank you.
Have a good one.
Thank you for the invitation, Brady. I appreciate it. You guys have a good evening.
It's my pleasure. We'll see you at the next one.
Yes, sir.
Thank you. Have a good day.
Okay, bye-bye. Thank you. All right, everyone, I'm going to close the room down unless you had any questions for me, and that's why you stayed on. Rebecca Lee doesn't have a question? Okay. Well, everybody, thank you very much for attending, and we will see you at the next one, which will be held soon. So thank you.